I understand PPP as cooperation and collaboration between public and private sectors to ensure funding, construction, renovation, management, or maintenance of provision of a health related service. And I think what makes it different is that it's a long relationship between the public and private sectors, and risks are shared. Now, I think this is a very interesting and unexploited model, especially in countries, in low and middle income countries where urban areas are growing, where demand is growing, but where public budgets remain highly constrained. So, we'll hear first from Sir Richard Feacham, who's the director of the Global Health Group. He's a professor of global health at UC San Francisco. He is also a visiting professor at London University and an honorary professor at University of Queensland, but he's probably very well known from his time heading another entity called a public-private partnership, the Global Fund for AIDS, TB, and Malaria, as well as the health group at the World Bank. So thank you and welcome, and I'll look forward to our discussion. So, Richard.
Well, good morning. Good morning, ladies and gentlemen. Great pleasure to be here. Many old friends in the audience. Thank you all for coming. It's a good turnout in the rain. So clearly, PPPs in healthcare are of interest and importance, as Amanda said. If anyone is on their iPhone and watching the BBC this morning, you might care to tell us if my country does something really, really stupid, and then we can defenestrate appropriately. Special thanks to Amanda and the team at CGD for hosting and organizing this morning's event. We are very grateful for that. My role this morning is to briefly set the scene, to introduce the collaboration between the Global Health Group at UCSF and PwC, to say a word about our panelists, and then to pass the ball to Nadia. In all countries, as we know, there is a never-ending quest to improve policies, to improve architecture, and to improve incentives to create health systems that can deliver on our universal public policy goals for the health sector, which of course include access, quality, financial protection, responsiveness, and improved health outcomes. And I think it's important to recognize that all countries are on this journey, and there is no nirvana to be achieved here. There is only a search for merit in the current lifetime. For example, the Affordable Care Act, I think of as Obama karma. It is a search for merit in health systems in the current lifetime, to be followed by endless reincarnation. For those who are surprised by this analogy, I've just returned from a lengthy visit to Tibet, so my head is slightly in the cloud, as you may detect. Tragically, at least half of all countries in the world are a long, long way from adequate performance, either in health financing or in healthcare delivery. And of course, much suffering and huge economic loss results from this large deficit in health systems performance. And many of us in this room work on that intensively. More positively, this disappointing performance in the health sector has stimulated a critical examination of previous policies and previous approaches. And this in turn, I think, has triggered a growing interest in innovation in mixed models of healthcare financing and mixed models of healthcare provision. Models which combine the strengths and competencies of the public sector, on the one hand, with those of the private sector, including NGO, faith-based, not-for-profit, and for-profit entities. And of course, there are many approaches to building well-regulated and high-performing mixed models. For example, a popular current theme in many countries is causing social health insurance schemes to contract with private providers as well as with public providers, as in the Philippines and elsewhere. But another important, as Amanda indicated, important growing and interesting approach to creating effective mixed models is PPPs, public-private partnerships in the health sector, which can take many forms and come in many shapes and sizes, as we will hear. So, stimulated by the findings of our private sector healthcare initiative at the Global Health Group and by the findings of 2 Wilton Park conferences on public-private partnerships in healthcare, which we convened, about 6 or 7 years ago, the Global Health Group at the University of California, San Francisco, reached out to our friends at PwC to create a fellowship program dedicated to better understanding and better documenting health sector PPP experience around the world, in wealthy countries, in middle-income countries, and in low-income countries. And to narrow the field, because that's a very big field, to narrow the field, we adopted a particular but not exclusive focus on PPIPs, public-private integrated partnerships, which are the full Monty of PPPs. They embrace finance, design, build, maintain, operate, and provide all services. They are the complete bundle in the PPP world. And we had a particular interest in those. You might think of those as horizontally integrated PPPs. We also had a particular interest, and I have a very strong personal interest, in vertically integrated PPIPs, which deliver primary and secondary and tertiary services, as in Valencia and as in Lesotho. The fellowship program has had 5 fellows, and you're about to meet the 5th fellow, and has completed 6 studies. And on the table outside are reports of a number of those studies, and Nadia will say more about the studies and how to access them. We have learned a lot during this process of working with PwC around the world. And my takeaways, very briefly, I'll mention 4 of them. My takeaways include, firstly, when you look, you find. There are far more PPPs out there than we know of, and they're far more varied in their design and their architecture than we previously realized. And we've had this experience of the Ministry of Health in country X not knowing all the PPPs in country X, never mind in country Y or country Z next door. So they are relatively undocumented, undescribed, and insufficiently known and studied, which was the purpose of the fellowship program, of course. Secondly, my second takeaway is that PPPs can achieve transformational improvement in quality, as in Lesotho, and significant improvement in efficiency, as in Valencia, and there are other examples. Thirdly, government capacity to manage PPPs is chronically deficient everywhere. And that's as true in the United Kingdom as it is in Peru or Lesotho. Government capacity to manage these kinds of relationships has to be enormously strengthened before a PPP has got a good chance of success. And lastly, especially in countries with an expectation that healthcare provision should be a public sector monopoly, countries like the United Kingdom and Spain and Lesotho, particularly in those countries where there is an expectation of a public sector dominance or even monopoly in healthcare provision, PPPs in the health sector are politically dynamite, and they will explode. Not may explode, they will explode, as our panelists know all too well, and we may hear a little bit more about that. So coming to the panelists, we are very fortunate, and I'm most grateful for our 3 panelists for being here today. They've come either a long way or a very long way, and they've interrupted extremely busy schedules to be with us. Paul de Rita has unrivaled PPP experience in health and other sectors worldwide, from his work many years ago with the British National Health Service and his leadership positions at PwC and the IFC. Alberto de Rosa is a private sector leader in Spain and has exceptional knowledge of the deep and broad experience in Valencia and Spain more broadly. And lastly, Tim Tahani has had the most distinguished career in global, regional, and national development finance, and is both the brains and the boldness behind the Lesotho PPIP, which we will be hearing more about. I think there are no three people on the planet with greater hands-on and frontline experience. And I emphasize hands-on and frontline experience because that's more important than academic experience or the study of. More hands-on and frontline experience of health sector PPPs than Paul, Alberto, and Tim. So thank you again for coming. We really appreciate that. And so I'm going to pass the ball to Nadia, our exceptionally talented fifth UCSF PwC fellow, to tell you much more than I can tell you about PPPs in the health sector. Over to Nadia.
Hi, everyone. Good morning. Thank you, Richard. Thank you, Amanda. Richard actually did such a wonderful job summarizing the fellowship, so I can add a little bit more to it. But as he mentioned, I am the fifth fellow as part of our fellowship program between UCSF Global Health Group as well as PwC. We did start this fellowship in 2012, and really the partnership between UCSF and PwC is intended to advance the study of PPPs in healthcare globally. This is an area that is not very well studied, and there's not a lot of information that is out there, and so that was part of our goal. We have had 5 fellows since 2012, and some of the areas that we have covered include a comprehensive case study outlining the PPP, the integrated model in Lesotho, as well as that across Valencia, Spain. We've also done a case study looking at the healthcare market around Latin America, where we've focused on Peru, Chile, and Mexico. And then we have a couple studies that are upcoming. So those first 3, you do have access to the executive summaries outside, and you can access them online as well. The ones that are coming are actually the report that I am currently working on, which is a business model report, really looking at all the different types of PPP healthcare models and their evolution, and what are some key lessons learned to inform future projects. We've really focused on facility-based PPP models, but as Richard mentioned, there are a wide variety of models that we don't cover. It's not a complete inventory, but this is a big focus of ours. And then we're also doing a market landscape on India, as well as one on Australia and South Asia. So why are UCSF and PwC so interested in PPPs? As you all know, governments face a very complex range of healthcare challenges that are spurred by key demographic and epidemiological trends. Changing demographics, rising urbanization, rising healthcare costs. And what we're seeing is that health systems are very pressured to deliver cost-effective care. And this pressure gets heightened as they're trying to implement universal healthcare coverage. We know that government spending on healthcare is unsustainable. Percent of GDP growing. Health spending as a percent of GDP is growing at rates that are unsustainable. And so countries are needing to seek different models for financing and delivery of healthcare. And there are many strategies that a government can take in working with the private sector to better improve the delivery of healthcare. And one of those strategies include public and private partnerships. And public and private partnerships, if structured appropriately, can inject competition, cost control, and innovation in public health delivery. Unfortunately, I can't get into the details of what all constitutes a PPP, but at a very high level, when we're talking about what a PPP is, it's a form of a long-term partnership, generally through a contracting arrangement between a government and private entity in which the skills and assets of the private sector are utilized in the delivery of public services. You will get a different definition of what a PPP is depending on who you ask. But the key characteristics, and what Amanda touched on earlier, is the long-term nature of the relationship. So some of these partnerships can last 30 plus years. Risk allocation is critical. And we do see that the private sector takes a lot of the financing, operational and technical risks, as well as a very, very important area is that these models should be based on performance. And there are indicators that are in the contracts so that the model is based on performance. When we look at healthcare, so PPPs generally started focused on an infrastructure-based model where we're looking at improving facilities. We have seen an evolution to more clinical service-based models where you could have just delivery of discrete clinical services, or moving to, as Richard mentioned, a more integrated model approach, what is referenced as a public-private integrated partnership. And those are the two models that we're going to talk closely around from Valencia as well as Lesotho. And as you move from the infrastructure model to this more integrated model, they become a lot more complex and extremely ambitious. And so we'll hear about some of the complexities in being able to put those models in place. Something extremely critical to consider when thinking about PPPs. Not all settings are equivalent, and there is not a one-size-fits-all PPP model that can be applied to any context. Really, you need to take into consideration the local context and the local health delivery needs and the broader health system needs. So there are many drivers in which governments may look to implement a PPP, including infrastructure. So thinking about replacing aging facilities, financing due to budget constraints, a need to access skills and human resources for the delivery of services, a need for improved technology and processes, and a need for additional service capacity. So all the drivers are going to be different based on the local context, and some may have, good facilities, but need help in the actual service delivery. So we really need to take into account the local context when considering what type of PPP model to implement. This is a slide I will not go into detail because I know there's a lot on here, but as we have looked at different case studies, there's so many conditions that need to be in place for a model to be successful, and PPPs are extremely complex. And so when you're thinking about good policy decision-making around PPPs in general, really a good understanding of what the health system needs are critical, what the demand for services are, and the current cost in delivering those services. Many will argue that political will is probably the most important condition that needs to be in place, so having broad political backing for working closely with the private sector. But there are some other very important things as well. So having a very clearly defined project, the right partners that have the right capacity and skills, a transparent process from the bidding all the way through implementation of the project, as well as flexible contract, clear communication, and meaningful stakeholder engagement. And another area is like a strong legislative and regulatory environment. So with that, you can see that it takes a lot to get one of these projects to work really well, and we have some great experience on the panel to be able to speak to what conditions really help them with their projects. One thing I wanted to touch on, and my last point, is as we've seen the model kind of shift to more clinical service delivery, one thing I wanted to touch on is we really should be looking at PPPs as a way to purchase services and not infrastructure. So when we've seen clinical services included in the PPP model, they've really focused on the areas that are in this visual. Not many go beyond tertiary care, and a few even touch on primary care. So can PPPs be used to incorporate more innovative care models across the continuum of care? Will we see more PPPs that incorporate primary care services, or even go all the way to think about long-term care? So this is a question that I hope we touch on during the panel, because I know both Valencia and Lesotho have incorporated primary care. And I know a question that Amanda, you have posed before is how do governments manage the trade-off between investing in just hospitals versus in other care areas, such as primary care? So with that, I'll turn it back to Amanda, and thank you.
So we've moved you one over.
Yeah.
Okay. Well, thanks a
we
lot to our
decided
panelists.
To change around. Okay, you sit down.
Well, I want to start with a question that I'll ask all three of you to respond to. And that is, what was the initial motivation of the public sector, of the healthcare payer, for a PPP. What was that PPP expected to accomplish ex ante? What did it actually accomplish? Not ex post, but several years later. And can you tell us a little bit about the politics and economics of all of this too? So maybe I'll start here with you, since you're to my exact right.
Well, firstly, I would like to give thanks for the invitation to be here in this event and in this panel. Thank you very much for the invitation. I'm sorry because my English is not good, so well, I will try to explain. I promise you, I know more about PPP projects than my English can show. But well, I think in the intervention of the people that have told before, I think it was very interesting about to put in this idea of the PPP projects in the perfect situation. I think politicians, in our case, for example, they needed, in 1997, they needed to build a hospital, and they want to give the opportunity to introduce the collaboration between the public sector and the private company to develop this experience. Not more than that at the beginning. Of course, when they saw the project was very well accepted by the population, the success of the management, well, they changed their opinion. But at the first moment, the idea was to build a hospital and to collaborate with the private sector, only that.
And did they ever compare the performance of the public hospitals with the private hospitals? And what kind of comparisons were they doing?
No, I always say we are part of the public sector. We are another public hospital and another public department of health because we have an integrated model, hospital and primary care. And of course, the government, every year they have all of our outcomes, or they evaluate every year our model and with the rest of the public hospitals, and of course in the 5-6 positions are the 5 projects with PPP projects. The first 5-6 positions every year we are in the. But I think we have more capacities to manage better. It's not a problem that we are the best, no. The problem is the public sector, the bureaucracy of the public sector, the lack of flexibility, the lack of innovation. For example, Alcira was the first hospital in Spain with electronic clinical record. It was the first hospital in Spain. I know it's very easy to explain now this, and it was very complicated to introduce the technology in the healthcare sector, but in our DNA, the technology is part of our vision of the new healthcare system. So, of course, it's easier to manage from the private sector.
So what about you? Can you think about an experience that you've been involved in, and so what was the initial motivation? What were the results, pros and cons? The other question I have is that, a payer or a government is treating the same kinds of facilities differently, right? So you have a performance contract. Does the other kind of hospital have a performance contract? How does that all work? Tell us.
Okay, so first of all, good morning, and thank you also to CGD and UCSF for the invitation. And I apologise for bringing the London weather with me today. Hopefully it'll go away soon. So let me give you a little bit of my experience back in the mid-1990s when the UK government first started to think about PPPs in the healthcare sector. And this really goes to one of the points that Nadia raised earlier about understanding what you're trying to achieve, what problem you're trying to solve when trying to design a PPP. So the UK government had basically neglected its hospital infrastructure for 40, 50 years, hadn't built anything new for many a year, and the 2 or 3 examples of where it had built public hospitals, it had done it really badly. So The two most recent examples back in the 90s were the Chelsea Westminster Hospital in London, where they were 3 years late with the construction and something like 300% of the budget. And Guy's Hospital, where again, similar experience of a public sector contract that was years late, and in effect, 5 years later had to be almost rebuilt from the inside out because it was full of defects. So the key issue for government here was, how do I find a model that gives me a better outcome in construction and on price? Now, at the same time, of course, we have to be realistic and accept that there was also a bit of a fiscal crisis in the UK. So they were also looking for models that would, in effect, allow them to invest in public infrastructure without it counting as public debt. So, you know, that clearly also had a role to play in how they defined the model. But the key theme of the model really was about constructing or putting together a long-term contract that was less focused on buying a building and more focused on buying a long-term maintained service. And again, goes to Nadia's point. And actually the reality is that in over a period of about 10 years, the UK government built around 100 hospitals through this method, with about 80% of those coming in on time and on budget. Now, you know, people will look at the UK PPP market and rightly say that it has its issues, and it does. I would argue that most of those issues are not related to the PPP model per se. They are more related to the way the hospitals themselves were planned, and to the way that the government, frankly, failed to deal with too much capacity in the system. But if you think about those two things that they were trying to achieve, which was certainty on cost and certainty on time, they largely achieved those things.
Interesting. Tim, how you were in government and thinking about the utility of the PPP. Tell us about that.
Well, thank you very much, Amanda, and good morning, everybody. I'm glad to be here. Allow me to digress for
Please.
1 minute.
Okay.
I just want to say thank you publicly to Paul. When he was at the IFC, we were struggling in Lesotho with the issue of what to do with the healthcare system and the political pressures that were in there. And IFC was helpful. We finally engaged them as transaction advisors. And Paul and his colleagues struggled, and some of them even had soiled reputations and everything, but I'm glad we are here today talking about success stories in different ways. First of all, Lesotho being a small country, facing serious budgetary constraints, resource constraints, skills constraint, facing a fragmented health system and delivery that was questionable. And I was appointed Minister of Finance and Development Planning, and the hospital that had been there was 100 years old, and infrastructure crumbling, staff morale, turnover high, and it had been decided in the 1993 political elections to replace that hospital. But for 10 years, they couldn't because the resources were just not there. I was thrown into that situation. They say, after 10 years, you have to do it. Second, the government was facing another free primary education, and we were going at it. And the third priority was providing pension funds for all people who are 70 and above. There were other priorities, but I just mentioned those which affected people. And the first a step after looking at this, realizing we just cannot afford it, for me was to go to the Prime Minister and say, we have to do something. And we said, I don't care what you do, but you have to deliver on the hospital, or else the next elections, we are out. And so the first point is health reform, health sector, hospital, whatever you want to do it, it's a political process. And in the US, I think you know even more about it. Then I arranged a review in my ministry, finance, of all the infrastructure PPPs, what we could learn, and also looked at some of the literature and what Richard and others had written, and decided to hold a workshop for the cabinet so that they also would be on the same footing. So a precondition in that situation is get a government commitment from the highest level. Cabinet is critical. The Prime Minister agreed. We had a whole day seminar, looked at the infrastructure in Latin America, Europe, UK, and concluded that PPP was an option we should pursue, because though we didn't have the prerequisite legislation and PPP and so on, but the contracts, we have been very consistent in honoring our contracts and everything, and we thought the private sector would come in. We moved on from there and said, no, we cannot move to the health sector directly. So we did a simpler pilot, which was the office accommodation for the Ministry of Public Works headquarters, so that we could learn and the bureaucracy could understand the thing. And that went very well, and then we moved on to the health sector. What did we expect? First, we wanted the poor people of Lesotho to have access to the same services at the same price that the public servants and higher income people were having. It's very critical to define the group. What group do you want to focus on? What do you want to give them? And what cost? So we did that. Then we moved from there to other things. Nadia mentioned a lot, and we wanted to involve the local doctors and so on. So for the design part, we involved the hospital personnel working groups, and they worked with IFC and reported to me and my colleague, the Minister of Health. That partnership between finance and health is critical for the public sector. And we participated. I then reported to Cabinet. So the whole project was guided by the Minister of Finance and the Minister of Health with Cabinet oversight. Political commitment from the highest level is critical. Once that was done, the tendering and so on was done according to the international ICB and all that. And we also said we expect the construction to come in on budget and on time. So the efficiency part came in. The building was delivered on that basis, no problem. Since we bundled everything, but for analytical purposes, we still had to consider each of the things. The equipment, maintenance, of the buildings, the equipment, the acquisition, and also the clinical services, non-clinical, we had put the private sector. So we had to put an independent monitor to monitor the performance of the parties. And any party that did not deliver on its benefit, on its responsibilities, had to pay. And that has happened. We then moved on to say, if it's a hospital, it has to retain accreditation. And that accreditation we didn't have in the previous hospital, but the new one has to have it. And we went through and we got the regional accreditation. This is another very important part. The other last point I want to refer to is Lesotho is surrounded by South Africa with advanced medical service facilities. We had many people around the border who were now going across to South Africa to avoid poor services and so on. Some were justified being specialties and so on that we didn't have. So we had to put in place, the objective was to reduce that. We put in place the mechanism for approving referrals to South Africa. And unfortunately, that didn't work very well from the government as well. The last part I want to mention, we began this project having done a baseline study of what the conditions were, both in Quinto and the system as a whole, because this can never be done in isolation. It has to be within a system. That baseline study was kept on being updated as we implemented the project. And how did we want to accomplish the other objective of saying poor people must have the same basis and government must have predictability in budget? We calculated the unitary cost. And it's regrettable that many questions have been raised in the media by some of quote unquote our supporters, NGO supporters, and the integrity of those who calculated those and the questioned. But it is important for the NGOs and everybody, and academics. We are thinking of these questions in real terms, in the real world. Take it easy, be constructive in your criticism. I think it's important to note that all countries are not the same, and they're different. Their political interests, their professional interests, their ethical questions, their social philosophies, and we had to manage those. So if I were to just, maybe I'll come back to some of those things, but let me stop here and say, political commitment is absolutely important. Dialogue with the private sector, but you will still encounter ideological biases along the way. You will still consider criticism of vested interest in the old system. And you, as a political leader or a minister, you must be prepared to face them and accept that your reputation will be soiled.
Wow. Okay. So it's a very challenging. Let me ask you, connected to that point that you're making, and maybe return to you, Alberto and Paul. The contract that's in place between the public sector and the PPP tell us how those difficult incentives are managed. So, you know, there's sometimes charges, conflict of interest, producing more of something, or overestimating costs. How are those kinds of conflict of interest managed in the contracts? What kinds of incentives are created? What kinds of performance measures are used? And then, so interesting, Tim, that you've mentioned the independent verification of some of these kinds of performance measures. Is that common in other PPP settings? So, because of this difficulty of the payer having the capacity to oversee some of these kinds of things. And then a final question is the role of international agencies in this space. I mean, I think that's an interesting role for the international community, agencies like the World Bank or the IFC, in terms of that kind of independent verification and contract support. So maybe starting with you, Paul, and then we'll come to you, Alberto.
Sure. A lot of questions there. Let me see if I can
I couldn't help it. I was free associating.
deal with all of those.
Yeah.
So, I mean, let's be clear. These are complex contracts, right? You're entering into a relationship that in many cases lasts, as Nadia says, 25, 30 years or more. And in that contract, you're trying to foresee as many of the situations that might arise over that period of time as you possibly can, whilst at the same time maintaining certainty over price, for instance. And we hear a lot about, you know, that PPP contracts are inflexible by their nature, and there's a certain truth to that, absolutely. But it's because one of the key government aims is to have that cost certainty, and so with cost certainty comes lack of flexibility. You can't have both to that extent. So the incentives around flexibility are more about ensuring you have processes in the contract by which you institute change. So that you're clear about who has what responsibility for that change, how do you make sure that you're getting value in terms of cost for that change, and what recourse do you have if the change is not implemented as you expect. So those mechanisms exist in most of those contracts. The incentives point is always an important one, clearly. And before you can think about the incentives, you have to make sure that you've articulated very clearly what your project is. And I think it's important to bear in mind that ultimately PPPs are a procurement method and a financing method. They will not turn a bad project into a good one. So unless, and actually I say that because we see that a lot. In many governments, when they're struggling with a particular issue in their health sector, their solution is to go out to the private sector to solve that issue when they have not yet been able to articulate it themselves. So that's the first step in all of these contracts, is a clear articulation of what you're trying to achieve, and the contract then can reflect that project. And so the incentives become then critical. So let me give you, just go back to the UK example that I started with, and I apologise for being UK-centric for a moment, but one of the reasons that the UK public sector struggled to build public infrastructure was the way that they were set up, right? So they used to have a design competition where they would hire architects to come and design the project. They would then take that design and they would go into the market and hire a contractor to come and build that design, and they would pay on a milestone basis. So they would pay as the construction went on. The incentive here was for the private sector to basically take as long as possible to build the thing, because the longer they were there for, the more payment they got. And they were also incentivized to encourage the client to make changes to the design, because again, that meant more money and more time for them. The PPP structure turned that on its head, because what it did overnight was to say, actually, we're not paying the contractor, first of all, and we're not separately designing the building. What we're actually buying is a serviced facility, and we will not pay a penny until that facility is up and running. So now the contractor is incentivized much more to finish on time, and because the contractor is now also liable for damages to the banks if they're late, they're now much more likely to finish on time. So that's just one example of how contract incentives can drive that behavior. But of course, during the life of the contract, you want also to be able to make sure you're getting the right outputs from the contract, and you want to make sure that if you're not getting the right outputs, that you have remedies in the contract. So again, as Nadia has already mentioned, these are all performance-based contracts. So all the contracts will have performance indicators that will be measured on a regular basis. And if those performance indicators are not met, then typically there will be a deduction to the payments made to the private sector. So again, you're very closely aligning payment with performance. In some cases, all of the payment is at risk. So in a particularly bad period, for instance, the private sector may get paid zero. In some cases, that's not quite been achieved, but there are caps in place as to how much you can deduct. But certainly all the contracts I've ever been involved with all have some sort of performance-based system that is directly linked to the payment the private sector receives. On your other point of the independent certifier, I mean, this is less common. So I would say, in my experience, I've seen probably a handful of contracts that have this notion of an independent certifier. And I think it has some positives in that it, you know, if you're in an environment where the government has low capacity to manage the contract, then that's a positive. But I think it also has a negative, and that's that it never really incentivizes the government to build that capacity because it's always relying on somebody else. And ultimately, to me at least, the preferred solution is to have an informed client who understands the contract, who can monitor the contract.
Interesting. And what about from your perspective, because you're facing some of these incentives in the contracts, how do you perceive them? What is working? What's difficult?
Well, I think one of the most difficult things I had to face at the beginning was to build trust between the administration, the public, the government, and the private company. Because it's true in our case, we began from the scratch. We didn't have precedent, and we built everything. To align objectives, to build consensus. I always say that it's very important to talk, but maybe it's more important to listen to the other part, because if you don't align the objectives from the government and from the private sector, it will be difficult, because you are a partner for 15 years, 20 years, 30 years. Well, it's one idea I wanted to explain. The other is a cultural change. Other of the challenges we have to face in the past was this is a cultural change for everybody, for the politicians, for the professionals, for the managers, for the citizens, maybe. And it's a very complicated task, and I think it's a job that never ends. You always have to work in this line to build trust, to build consensus, to change the culture of the professionals, the politicians, and the private sector, because I understand and I know that the commitment of the government is very important. But I would like to introduce the idea that the private sector can be, not all the companies are the best companies for the PPP projects. For example, I don't like the idea to give the public healthcare sector to put the public health sector in hands of private equity, because this I think is important. Companies with a long-term vision, with loyalty with the government. We don't discuss the values of the system. We discuss maybe the management of the system, but not the values. I am very proud about the NHS in Spain. I am very proud. I think the citizens are very proud. But the citizens, they want to give solutions to waiting list, to new infrastructure, and to, I think the private sector can give better solutions than the government. But we are not discussing, have discussed about the healthcare system or about the values of the model. I defend the values of the model. So we can discuss about that, because I think the PPP requires a government open to collaborate with the private sector with a strong institutional framework. I think is very important. And a government open to change its role in the healthcare sector, because it's very important to design, to plan, to evaluate, to control, to audit these projects. And the private sector, the objective of the private sector is to introduce flexibility, innovation, knowledge, financial resources, but we must align these two. In our case, for example, we were the first experience in Europe to introduce the capitated payment into the model. So that idea for us is very important because in 1999 it was very revolutionary, the idea, and now in Spain at least is very revolutionary too. The idea to the government pay us in a capitative basement. They pay 750 euros per citizen per year in our catchment area. So the government finance health. So what is the objective of the government? To achieve the best health condition for the citizens. But as a private company, if we achieve the best health condition for the citizens, it will be the best for us. So I think this align was important in our case. But the idea is to align, to build trust, and to have a similar vision between the government and the private companies.
Yeah, that makes a lot of sense. Let's just do one more round before we go to the audience, so prepare yourselves. On the issue of human resources. So, one of the difficulties sometimes with public sector employment when you're trying to contract very, specialists or very well qualified health staff, you set up a different human resources contracting model. Maybe you're paying more. The conditions are different than they would be if you were employed by the public sector. What are the politics of that? What does that do to the distribution of health staff? Was that one of the reasons to consider integration vertically? Tim, tell us about that.
Well, the first point I think about the human resources, let me start from the general. A facility, it's a building.
Yeah.
Without the people, we don't have any hospital, and without the equipment and the drugs and medicines. So human beings and their skills are very critical. But the minute you have a collection of human beings, management becomes critical, and delivery becomes critical. So the conditions were so bad when we were designing, we put nurses, doctors, and so on, and got a team so they knew what was coming. And then we said, let us recruit. Let's allow the hospital to recruit from the existing staff, and those who do not make it will become a problem of government. So that's another area that brought us into conflict later. The working conditions were better. So we had no problem getting people, and they could be retained in the new facility. But then the government decided, there was a change of government, and the new government increased the salaries very substantially for the health professionals as a whole, and doctors and nurses. And then we had a problem from the new hospital where we had a strike for salaries and so on. So all I can say is that the issue of remuneration has to be handled carefully. Government has to consider the impact of its own decisions on the private sector. Otherwise, you run into the negative publicity and patients suffering, because now people in the new hospital wanted their salaries immediately to go up, or else they went back into government. But it hasn't happened because the conditions are much better. And thirdly, let me say another point. The private sector brought in the modern diagnostic equipment. And so we found ourselves attracting some fairly good young doctors and so on who wanted to use the imagery and so on for diagnostic purposes. So if you are looking for a successful PPP, I think you need to pay particular attention to the management of the human being and the system as a whole. That we didn't succeed very well in terms of the change of government. And later on, I think I would say you have to institutionalize and have the unit that is dedicated to managing the private-public partnership. If you don't have that, you lose a lot of knowledge. And communication becomes extremely important for gaining public support. But let me close by saying, you know, ministers and politicians, we love to say, this should be that, this should be that. But when it's your own child or your own mother that's involved, philosophy goes through the window. You just want somebody to attend to that. And we found ourselves in that situation. And taking back the transfer patients to South Africa were taken out there because some politicians did not want to queue up and go through the registration like anybody else. So they rushed to South Africa. So let me simply say human beings are very critical in the health sector. The politics, that's what makes the politics of health reform and so on very, very serious for any government.
Yeah. It's not nirvana, like Sir Richard mentioned. Alberto, what about this issue of human resource remuneration in your system, PPP system, versus the sort of status quo?
Well, two ideas. The first idea is, I think we are in the midst of a tsunami of changes, demographic changes, social changes, therapeutical and technological changes. So the professionals are your ally in this process of give solutions, new solutions to these new problems we have at this moment in our healthcare system. In the traditional public system, the employees for the government, the bureaucracy, the salary is the same for everybody. And well, we have the opportunity to change this process and to apply human resources policies that the 21st century. I try to explain that I think it's not possible to manage this sector as 50 years ago. We have to change and to change our vision. And for that, part of the salary of our doctors and nurses are flexible and with clinical incentives, clinical objectives, and if they we get that clinical objectives, part of the salary is involved in that. But no a small part. More than 20% of the salary of the doctors and nurses are related with the clinical objectives. So it's very important to align. If before I said it's important to align the company with the government, we have to align our professional with our objectives as a company, because our objectives as a company is aligned with the objectives for the government. I always say the idea of the triangle of success. For me, the triangle of success is to work at the same time in 3 different lines. IT systems, because we need to know what we are doing, what are we doing, how are we doing, etc. Clinical management and human resources. We have to work in these 3 lines at the same time. And the human resources is our main asset, and it's ally in this process of change, and part of the salary is
Is it risk based on quality improvements or quality metrics? What about last word on this topic?
Yeah,
what have you seen?
Very, very quickly. So, I mean, if you think about the primary objectives of some of the PPPs that I've seen, it's really about trying to get more for less. So can we get a more efficient operation through a PPP? And of course, that immediately raises fears in people's minds. That means cutting salaries, cutting headcount. And given that, you know, in most places, 60% of your cost bases are your staff, that's understandable. But again, depending on your objectives as a government, you can deal with most of those issues. So I've seen, for instance, contracts where the private sector has the option to take on the public staff, but if it does, then it must at least maintain many of their conditions. So whether it's pensions, whether it's other benefits, it needs to maintain some of those conditions. It may do what it wants with headcount. So if it decides it needs less headcount to deliver the service, then of course it has that freedom. Excuse me. But it has to at least take on some of the benefits. So and this is, you know, pensions being the most obvious thing that people get very concerned about, particularly if they have long service in the public sector and are now being faced with transferring to the private sector. So you can put some of those protections in place if that's what you're trying to do. But ultimately, I think the evidence that I've seen certainly is that when public staff transfer across to the private sector and are still delivering a public service, in many cases, they find themselves actually with much more rewarding career because they have much more opportunity. They can move into other parts of that company. They can move to other companies. And so actually the evidence that I've seen certainly has been a largely positive one.
Interesting. Okay, now it's time for you to make your interventions. So please introduce yourself and where you work if relevant. So we'll start here in the middle. A microphone is coming to you here in the front.
Thank you. My name is Willie DeGain, formerly with the World Bank, currently professor at Georgetown University in International Health. I want to pick up on a couple of points made by the speakers. PPP, from my point of view, requires a strong public partner. This was mentioned by Nadia in terms of public sector capacity. It was mentioned by Richard, in terms of management capacity also. The priority, therefore, from my point of view, is to help the public sector to become strong. My hypothesis is that the intermediate step to successful PPP is to provide financial and managerial autonomy to our large hospitals. Once you have a successful autonomous hospital, okay, you have a partner to create a PPP. You also will have developed a political will that Mr. Tahani is talking about. You're talking about the building the trust that one speaker mentioned. So I view that as an intermediate step, towards a successful PPP. Because my research in Africa, especially, where I've seen Lesotho is the poster child, of course, of PPP. There's also Cross River State in Nigeria with IFC money, but that's about it in Africa in terms of PPP. So we are working much more on hospital autonomy as a preliminary step towards a PPP model. Okay,
Okay, we'll gather 3 questions in the row behind, and then up here.
Hello, I'm Guy Pfefferman of the Global Business School Network, formerly IFC and World Bank also.
I'm noticing a trend.
I had a question which hasn't been touched on. If I were a junior minister or high official of an African government, finance, health, whatever, is there a place I could go and spend 6 months at the university and learn about PPP, all there is to know? And then what would you say are the 2 or 3 centers of excellence, if there are such courses given in the world? And are there any in Africa?
Okay, great. Over here.
Good morning. My name is David Jamieson from Crown Agents and the Partnership for Supply Chain Management. and it's supply chain that is my main focus. One of the key, I've particularly taken by, firstly by the remark of Sir Richard about the horizontal integration that you can achieve through PPPs. One of the key problems we find in many African health systems is that they're very fragmented across disease or health lines, often driven by donors, and we see vertical supply chains. Do you think that that is something that, a couple of questions for the panel, does that undermine the potential to put in a PPP, or on the positive side, could a well-designed PPP actually bring those fragmented operations, implementations, into a more integrated structure?
Okay, great. And let's take one last, Anit in the back, and then we'll do a round.
Good morning,
and come back
Anit
to you.
Mukherjee from Center for Global Development and not World Bank or IFC.
Just for some diversity.
Just a fascinating discussion. One of the things that when I was working back in India is that the PPP is kind of more in tune with an infrastructure project. So the PPP's concept started with infrastructure. And we find it incredibly difficult to translate that into health or education. So what are the learnings for developing countries from moving to a system, to something like a Valencia or a Lesotho in terms of having actual PPPs and rather than just business process outsourcing within the health system?
Okay, great. So we have one question about whether financial and managerial autonomy of public hospitals could be a kind of incubator for an eventual PPP or a prerequisite. And my question also is, are there prerequisites, or is the idea that creating these new incentives creates the necessity to actually build the capacity that's needed? Our second question was, where could I train in doing PPPs if you had to name a place? And then the third is around whether PPPs might help or hurt would it help with the excessive donor fragmentation, especially in low-income countries? And I don't know if in Lesotho you have something to say about that. And then finally, PPP started in infrastructure. Why is it so hard to, well, there is more than we think, I guess, is what Richard was saying. But you don't see it at a massive scale, let's put it that way. So, Tim?
Well, let me start simply by saying that PPPs, yes, started in infrastructure. And our review did confirm that. Then you have to start asking, why not in education? And why not on anything else? And the World Bank initially used to be a crucible for new ideas, for thinking horizontally and so on. But I don't know nowadays because I'm now off. But let me say this. If you look at the European Investment Bank website and their publications, their Journal of Budgeting and all that, you do have PPPs. They are being used in health and building stadium and so on. You know, in Europe, they are being used extensively. And you have a blunt question to answer. Why should the African countries not experiment? Why should a low-income country sit around, see its people die, and inefficiency continue until the work in Europe has been done and perfected? That says to me, for the African countries, we don't have to go through the cycle. We need to shortcut the system by leapfrogging. And in that process, you have to pick up what is doable within your own environment. And if it's not working well, correct it and move on, rather than spend time fighting to say it has to be this way. No, it doesn't have to be that way. So I'm pragmatic, but there is a lot of work And as you have seen from Nadia's study, in Latin America, there are more than 20 PPPs. When you include Brazil there, Brazil alone has 17, double the number that you have there. So there is a lot that's going on. Second, as far as Guy's point about where to go, I'm not an academic, but all I've been doing is reading and finding there are short courses given in Washington and different places, and I don't know, maybe it's people who just want to advertise on the web, but I think the best people, Richard and others who are on both sides, can advise where you can spend 6 months. If not, let's talk. I will find a place for you. You might go where you might go and do a case study, and you are good at that. Lastly, I think the issue of finance and management autonomy is critical. Hospitals are a very, very substantial component in terms of expenditure on health. And if you are going to reform the system to focus on outputs and performance, then it may help to start with that major percentage of expenditures rather than start with the smaller pieces down somewhere. And I agree with the issue that management includes autonomy to make decisions, and public sector reforms have to bring that into account.
Okay, Paul?
Sure, so let me start with a simple one. So the Centre of Excellence. So actually, and let me give the World Bank a plug here. The World Bank has actually built an accreditation course for PPPs that's available online. So people can go online, sign up for that course, and use that as a learning tool. But other than that, there isn't anything that I've come across that is as in-depth as what you're looking for. In my time at IFC, we developed a short 1-week syllabus with Frankfurt School of Business, which they've now run for 3 years. And I hear that they're about to stop running it because there's no uptake. So there isn't a huge amount of formal training out there that I've come across, certainly. Again, IFC does a broad infrastructure training week for government clients and others with Harvard that it's run, I think, for the past 7 or 8 years, which is very good. But again, it's a very short, focused piece of training. I think, is there a need for something like that? Absolutely. But it's not out there as far as I can see. Just moving quickly to some of the other points, and I'm conscious of time. But so your question about autonomy, in my experience, anything that allows decision making to be made on a timely basis and that allows focus on what you're trying to achieve is always a positive step. So from that point of view, autonomy is absolutely helpful in terms of achieving a PPP. However, I think that comes with a bit of a warning, which is that, again, in my experience, one of the biggest reasons why PPPs don't always succeed is that they're not fully integrated into the health system. And so I would advise very, very strongly that if you're looking at using autonomy as a way of then allowing conditions to do a PPP, that you make sure you don't somehow disintegrate that project from the rest of the health system. Mm-hmm. On the issue of the focus on disease management, I think there's certainly some truth to the point that the focus on single diseases has not always been helpful in terms of integration of PPPs into the wider system. Certainly what I see is actually even some of the main donors now moving away from single disease focus much more into systems focus, and I think that's a positive step. So hopefully we will see more of that, and I think certainly well-structured, well-articulated PPPs can play a role in integrating various health components together, absolutely. On the last point of learning from infrastructure and why it's so difficult to do in healthcare, I think there's a structural issue here, which I think over time you may see some change. So historically, because PPPs are focused on hard assets, you've had PPPs led by and large by construction companies, right? And so construction companies, when it comes to understanding healthcare, it's not something they do. So the minute you talk about having an integrated PPP that includes service delivery, those guys get very, very nervous and walk away. So until you start seeing PPPs being headed up by service providers, then I think that will remain a struggle. But where I've seen examples, for instance, of hospital operators being the anchor person in a PPP consortium, then that becomes much, much easier. And actually, even in India, where we've seen some very interesting projects that have been service-led. So whether they be things like diagnostic services that bring not just infrastructure and equipment, but actually a service provider at the front of that, then we see the structuring of the projects and actually the success being much more easy to achieve.
Well, firstly, I would like to tell you what is the definition of PPP for me. It's not the same that Amanda, but Amanda, I'm sure.
It's no worries.
For me, it's the joint action of public and private organizations to create public value for the citizens. Mm-hmm. So, in my opinion, the traditional British PFI, that is, the idea is to private sector invest to build a new infrastructure and to manage all the non-clinical services, for me, not a real PPP project, because the problem in the healthcare system is not to build new infrastructure, is to manage the expenditure that that infrastructure generate to the public sector. So, in my opinion, I understand that maybe it could be to the debate. Well, secondly, so I think we need companies that introduce knowledge, flexibility, innovation in the traditional public sector, and this is to create public values for the citizen. This is my opinion. Because that, I think the autonomy is very important. For example, in our case, we have set more advanced health promotion plans and programs than the government. Because in our case, for example, the capitated payment, our culture is to give new solutions, and not only in the hospital, in primary care, in social services, in nursing home, because we need to change our vision of the healthcare. Healthcare is not the hospital, it's all the network around the healthcare. Schools, nursing homes, home, primary care, social services, hospital. Hospital is a part of the healthcare process. It's a important part because it's in the acute process. But to achieve the best condition, the health condition for the citizens, you need to work with all the network. So we need autonomy. We need autonomy to work, because this is the problem of the traditional public sector. We need autonomy to work, and I think it's important transparency and evaluation. Everything that comes from public funds, in my opinion, must be analyzed, exposed, and evaluated, and if they don't work well, they must be removed. So, because it's very serious our projects, and this idea to the collaboration between private sector and public administration or with the government in healthcare. I don't know in the rest of the sectors, but in healthcare is very important. Course of PPP, I think is important. It's important to introduce these ideas for the professionals of the future, because I think it's impossible to maintain our healthcare system if not include new solutions, new opportunities to work together introduce knowledge and to introduce innovation. So I think it will be a good idea to have a course of PPPs.
Okay, good. So we'll look forward to having you set that up. Okay, so it's now 10:30. I think we can continue on, but if you do need to leave, since we announced that we would end at 10:30, go ahead. But let's take another round of questions in the meantime, starting over here on the right.
Hi, my name's Katie Cheney. I'm with Panagora Group. And my question is about PPPs and gender. Knowing that women's access to healthcare is very different, and women, of course, have different healthcare needs. I'm wondering how PPPs thus far have acknowledged and incorporated gender, and also how PPPs can advance gender empowerment for women's health.
Okay. Behind? Yeah.
I'm Lucy Mize. I'm the head of the Asia health team for USAID. And so I'm waiting for your next two reports on the India landscape, and those will be interesting. But my question is, how do you integrate public-private partnerships at all levels of the health system? It's your network question, to address a specific and significant public health challenge. Because in our region, we're looking at MDR TB, and we've had very successful PPPs at the tertiary level with the introduction of GeneX machines and bedaquiline. But at the primary level, the private sector is implicated in poor management, bad diagnosis, bad prescribing practices, not the follow-up. And how could we address that or incentivize them at the primary level to match some of the successes we've had at the tertiary level?
Okay, great. Thanks, Lucy. Okay, then in the white shirt, and then we'll do blue shirt, and then we'll
Thanks, Alexa Strauss. I'm with the International Relations team of Medtronic, and we actually do have a couple of PPPs in place. So I have two rather practical questions. You touched upon the importance of high-level support in the public sector, and we continuously face the issue of who to approach first. Do we go to the Minister of Finance? Do we go to the Minister of Health? Do we do it simultaneously? And any other relevant advice you would have for us how to get a PPP off the ground, because that we continuously struggle with the stallment of PPPs before they actually really set off. So those were my two questions.
Okay, thank you. And finally, in the back.
Hi, my name is Phil Thomas. I'm adjunct faculty at George Mason University School of Policy and Government. We're doing a lot of work on food security and PPPs. And I'm struck by the fact that this is a health group, and I'm probably the only person here on food security issues. And there is obviously an interrelationship between health and food security. So that's one point. The other point is the importance of the NGO community. When we talk about PPPs, particularly with the Obama administration's Feed the Future, the emphasis seems to be on in-country private companies, in the host government, and the donor governments. It seems to me there needs to be a role cut out for NGOs to create a more integrated PPP, since in most of these countries, like the 19 countries that are food insecure that the Obama administration is targeting, the NGO presence is big and significant and can't be ignored in terms of PPPs. So, there is an issue here about PPPs. Rhetoric seems to outstrip reality. There is a lot of emphasis on food security about how wonderful private-public partnerships are. There's very little analysis of outcomes. There's a lot of data on output, but outputs are, a dime a dozen. And then the issue of, PEPFAR is kind of an example of political will, where you can get multiple interests from the private sector, from the NGO community, from the host government and the recipient governments to work together. Is there any benefit in taking that PEPFAR model and kind of blowing it up and seeing how we can apply it across the board. Thank you.
Okay, and I want to add a question that I was trying to probe on before. You mentioned some of the activities of the World Bank or others, and also the question from our colleague at Medtronic who says, who should I ask about it? But the idea is, okay, that as a health system, as a public payer, you would have a policy with respect to PPP, some objectives, some set of services you want to provide, some budget, and that the PPP piece fits in there. But I have a question about whether this is actually being offered to governments or discussed with governments actively. I haven't heard, I would say probably 8 years ago, I heard more about this. Now you barely hear any discussion of that at all. Does anyone have any thoughts on that as well? So I'll let you select from this list. We had gender, we had how do you consider the role of the private sector, different levels of care for PPPs, how to get them off the ground, relevance in sectors like food security. I must admit that I've never really understood what food security meant. Is it hunger? Is it agricultural production? What the heck is it? But we'll come back to that later. Could PEPFAR be doing more PPPs? Probably. So maybe starting with you, since you're making eye contact.
So yeah, where to start? So I guess maybe starting with the point about how you engage with governments. In my experience, the private sector is constantly engaging with governments at various levels and bringing ideas to governments. And it's either engaging, as you say, at the finance ministry level or at the Ministry of Health level, or indeed many other levels, whether they be municipal levels or national levels. And what I find is that unless the discussion, and I think this goes partly to your point, unless the discussion is grounded in some sort of policy context, the fact is you're unlikely to get traction, right? So you have to be, and therefore the context and the conversations, I think, have to originate within the Ministry of Health, because you have to try and fulfill their policy issues. I think it's absolutely critical that you then bring in the finance ministry, because ultimately, if you are entering into a PPP, you're entering into a long-term financial commitment, and the Ministry of Finance needs to be on board with that. I think Tim's point earlier of, you want to get political buy-in from the cabinet or the government as a whole, as opposed to just one ministry. So all of that is critical. My concern, and I've seen this a number of times, is that when engaging with those ministries, many times the private sector is promoting those things that it sees as valuable to them, not necessarily valuable to the public sector. And so we see, instances of and this is becoming more common, not less. We see the private sector bringing ideas to the Ministry of Health thinking, this sounds okay, I'm not really sure I need it, but let's go with it. And then you enter into some sort of process that has little transparency, little testing of value, and actually little knowledge as to whether it's really going to fulfill the needs that you need fulfilling. So I guess that's a long-winded way of saying, yes, of course, engage with the ministries. Health has to be first, I think, because you have to ground whatever you're trying to do in their policy context. So maybe to the primary care point, in my 3 years at IFC, the one thing I constantly struggled with was to get private sector interest into primary care. Partly because a lot of the times we're looking at primary care in rural settings, so it's difficult to staff. We're looking at relatively small patches of primary care that you can bring together into a project, so there's an issue of scale. And frankly, there's little profit in it. So getting the private sector interested in primary care alone has been a challenge. I think that
you found a company.
Yeah, I was about to say you beat me to it, but so I personally I think the way that you deal with that is to exactly follow this example, right? So you integrate primary care with secondary care with tertiary care, and you incentivize the private sector to provide care where it's most suitable, rather than having everybody going to hospital. And what that means is having some sort of payment system similar to this, so a capitation-based system where it's not in the interest of the private sector to admit people into hospital 5 times, 6 times a month. It's much more in their interest to look after them closer to home in a lower cost setting where it's more appropriate to deal with that condition. so I'm not saying anything new there. I guess I'm sure you've heard all of that before, but I think it's really about trying to integrate those components together in a way that you can manage them together. Would be my advice. I'd say on the gender question, I don't have any nuggets. I have to say, I've not seen any PPPs that have a specific focus on gender, other than at a very, very local level where, so for instance, I've seen projects that isolate within them maternal and childcare, for instance, in a way that they want the private sector to focus on the delivery of those services for obviously for women with children. But that's really as far as I've seen in terms of PPPs. I've not seen anything other than that. Like Amanda, I don't really know what food security means, so I'm not sure I can address that. Other than we've seen PPPs used, for instance, for things like the grain silos. So the construction and maintenance of grain silos in rural areas to allow you to at least store food in a more secure setting. But again, that's probably as far as my expertise goes in that area.
Okay, Alberto.
Well,
And then I'll make you go last. How about that?
Oh,
no. Okay,
well, sorry. No.
It's the inspirational ending, so get ready. Okay.
Well, I would like to start my intervention with the idea of the integrated model. I remember when we began our project in 1999, our contract was only for the hospital level. But with the capitated payment, we tried to convince, and at the end, we convinced to the government to include in our contract the primary care. And I think it was answering the question about the relationship with the government. I think it was one of our most important success, because for me it was the moment that everything was logical in the healthcare provision, because we had the same objectives in primary care, in the hospital. Doctors and nurses can share the objectives, the IT systems, everything. So it was very important. In fact, I think when we give some speech all around the world, I always say we are more a company that we have a primary care vision than hospital vision. I think the politicians, I think the private sector, the traditional private sector, always are thinking about hospitals, MRI, cities, but I think our objective as people that works in the healthcare sector is to achieve the best conditions for our citizens. So we have to work with the primary care very close and at home. Nursing homes, for example, in my country, nursing home is not included in the healthcare system. It's a social services, but we work with the nursing homes. Our IT system is in the nursing home because the citizen is the same in the nursing homes that in primary care, that in the home, in the hospital, and we need to see the citizen as a whole, as a person. So it's very important to us to work together. For example, we have developed a predictive model, a stratification model, a health portal to improve the communication between the citizens and the primary care doctors, the primary care doctor with the doctor in the hospital. Everything, for example, is the first time in my country that is developed, but I think it's the future.
Yeah.
I think the future of healthcare, you have the future of healthcare in your pocket. And we need to use this technology, these phones, these mobiles to improve the communication. Gender. I think caregiver, at least in my country, I don't know if it's good or not, but women are very important in the healthcare. So we have a lot of promotion and a lot of relationship with the Women Association of Patients and a lot of things, and we work a lot with them. And the idea to discussion actively with the government, well, in my country, we have, next Sunday, we have general elections, and this is a difficult moment in our region, in Valencia region, are a coalition of parties that they are against the PPP model. Why? Because they thought that the transparency of our projects, not for our reason, is for the reason of the former government. They don't know very well our projects, and our challenge now is to explain, to give figures, to give opinion of the citizens, to be transparency. For that, I think it's very important to be transparency and to have any independent observatory to evaluate everything we have, because I understand we are in the middle of a political debate and we don't like, it's not comfortable for us, but I understand we are in the middle of a political debate. But I think, for example, in a survey of 6 years ago, it's interesting, the 91% of population is happy with the service of our projects, and 94% of the population, they don't know when they go to the hospital or the primary care centers, they don't know if it's a PPP project, a traditional public hospital, they don't know anything about that. And I think it's very important because, in my opinion, the population, the public, is not worried about who manage, is worried about how manage. So I think it's important.
Okay, Tim.
Well, very briefly, I think it is important to have open dialogue between the private sector and the government. Many of the misunderstandings arise from past actions or beliefs of the ideological nature. And once you sit down, you'll find you don't disagree on many things. And so that would be my first point. When it comes to primary level, I think Paul has answered them. We found it's very difficult to move in the private sector, to move the private sector, or for the doctors and other professionals to go there. Sometimes there's no hot water, and the housing is bad, poor communications, and they want to see the TVs and so on. And so at the same time that we're developing this, we had to develop with the MCC Corporation here the improvement of the healthcare centers so that the conditions, the physical aspects, would be better to attract the people to stay there. And we also had to work on the technology. And we worked on the transport for motorcycles to take the blood from the health centers to the nearest facilities, and to be able to send from the district hospitals some radiologists. We have shortage of trained staff, so a radiologist sitting in the capital should be able to read the reports from elsewhere. So there is a lot of scope for participation and taking primary care to adherence for the mothers to be to their dates, and when you are dealing with HIV and AIDS, for some of them to be taking their medication, technology becomes important. So I don't think we should see the hospital as an island because it has a relationship with the rest of the system. Having moved, let me say, who do you approach first? It's a difficult one. The thing is, in a country, after the elections, who has primary responsibility for delivery of healthcare, of education, of infrastructure? Is the government. And there are usually many projects that are done, thrown around, and the planning process from the Ministry of Planning, or like in Lesotho at the time, it was finance and planning. So the definition of those projects and some of the studies, the private sector came in, and from there on you identified the projects that you started discussing seriously. So it is not who approaches who first, but is in that country, what are the priority needs that need to be addressed by the private sector and so on. I think the last point on that one is that there are changes in the private sector that are going on philosophically, operationally, and they recognize their social responsibility, that their continued profitability depends on their contribution to society. And let us not try and isolate each other. Food security is is problematic, but there is private-public partnership taking place within the agricultural and other sectors where the private sector is active. But we should look at what, if we open it up and break it down, what the NGO's contributions would be, what the government's contribution would be, what the private sector contributions would be. For the US, I don't know, but for developing countries, I would advocate isolating the activities and trying to get a sense of what is the value add that anybody brings, not the NGO per se, because they can also be destructive.
Okay, last 2 seconds. Are you done?
I'm finished.
Excellent.
Oh, if you want me to really close, I would simply say, I think dialogue like this is extremely important, and let's try and bring a few more people from developing countries who can bring their practical experience, and institutions that are used to audit the private and public sector, like PwC, I think need to be congratulated for coming forward like this. And thank you very much for the center.
Yeah, no, thanks to our panelists. Thanks a lot to UCSF and PwC for joining us. There are no silver bullets in healthcare, as you know, so this is one more tool for the toolkit. Thank you.